Hello and very warm welcome to this follow-up session to the Parosmia and Phantosmia Let's Talk Smell and Taste event from a couple of weeks ago. Today we have Sam Leong today who is going to pick up some of the questions that came up during that session. Sam, can I let you introduce yourself?
Thank you so much, Tom, and hello everyone. I'm Sam Leong. I'm a consultant working in Liverpool. I specialize in sinuses and noses. I'm one of 4 consultant rhinologists in the department, and the department has been seeing patients with olfactory dysfunction for probably over 2 decades now, starting with our senior consultant, Mr. Andrew Swift, who set up the smell service many years ago. We are a very busy department, and due to COVID, we're seeing a significant increase in patients being referred from their GPs with olfactory dysfunction. So hello again.
Thank you very much. So, we had a lot of questions come up during the session, so I'm just going to chuck as many as we can in this time we've got together today. So the subject we were looking at was Parosmia and Phantosmia. We put those together. I mean, I guess first question is, do those belong together as two areas of disorder dysfunction?
I think if you go back to the original description of Parosmia and Phantosmia, those who are didactic among the audience will say that it's all very different and distinct. But given that smell and olfaction is very subjective, it's very sometimes we have to accept that there will be significant overlaps between the two. Bearing in mind the terminology for Phantosmia is strictly perception of odor when there is nothing presented. But then again, some people might have a very acute sense of smell, and actually they might be picking up something that others don't in the room, outdoors, etc., etc. So extremely subjective, and certainly without undertaking objective testing in the individual, sometimes it's quite difficult to work out what patients might actually describe their olfactory dysfunction to be without actually seeing them and assessing them in clinic.
Got you. So Phantosmia, I mean, of course, it's very difficult to step into a space where there is no smell at all.
Yeah, but if you take the same person into that environment, and again, because this is the subjective nature of olfaction, some people might actually perceive something within the room. I think olfactory testing is very different from, say, hearing tests, where the room that people get their hearing tested in is completely soundproofed, and obviously that has all sorts of industry standards to adhere to, whereas when we take a history and we assess patients in the clinic room, it's almost impossible to mitigate those variants, really. Yeah.
Got you. Thank you. So stripping back, let's look at, let's concentrate on Parosmia then. What are the known causes of Parosmia?
The most common cause, certainly in our clinics, are post-viral, sometimes after head injury as well, but significantly less common. There are other causes like allergic rhinitis, inflammation, sometimes even after quite major sinus surgery, where patients do describe changes in how they perceive odor. But certainly in our clinics, our normal smell clinics, the most common reason is post-viral. And that normally results from very significant anosmia or hyposmia soon after the event. And then several months later, there is alteration to olfactory function.
Thank you. And I know that research is ongoing, but what do we know is happening in the cellular level in the olfactory bulbs?
Tricky question, this, because the research isn't specific and it's not at the moment very clear. And it's almost impossible to put one's finger on the pathophysiology. And certainly no one's been able to remap the neural networks to try and explain what parosmia is. From a cellular level, the cells are all there, the nerve ends are all there. And in my personal opinion, I think parosmia is something that is more distal from what we see within the nose. So it's that intricate, very complex neural communication from the olfactory bulb and further into the brain itself.
Thank you very much. And in your experience with patients, what are they telling you is happening? So what is their experience that they see?
The most common description of patients' parosmia is smelling of smoke or something burning, and not necessarily smoke, but it could be something that they would describe as either coming from the fireplace, wood burning, but most commonly it is smoke of some description. More uncommonly, patients will be describing stale food, but not necessarily cacosmia, which is unpleasant smell. It's just something that they are not familiar with or not expecting to perceive when they enter a particular environment.
So smoke being the most common one, and we're hearing quite a few people coming through with who are post-COVID, who are also getting areas of tarry smells as well. Is that one you've seen come up?
Tarry smell, I had one probably 2 to 3 weeks ago. But again, I think how people describe parosmia is related also to memory and what they are aware of or can remember or kind of form that kind of connections with. So we don't necessarily pick up on the first word that the patients describe, but it's trying to explore that even more to try and work out what that parosmia actually means for individual patients. But certainly the most common first word is smoke or something burning, certainly in our clinics anyway.
Thank you. I hope one of the questions came through. Interesting that it's normally smoke is a common theme. Perhaps is that linked to a heightened danger response? Was somebody speculating in there?
It is without doubt that olfactory dysfunction is linked to anxiety levels or causing anxiety levels and how they interplay thereafter and how they potentially cause a vicious cycle event is anecdotally recognized. I'm unaware of any scientific studies to kind of solidify or confirm that correlation. So maybe, absolutely maybe, but who knows?
And so in terms of when people are getting parosmia, there's a couple of comments that came up where it's sort of come and gone a little bit. So they maybe had anosmia for a while and then parosmia kicked in later, or they had anosmia, then a period of recovery, then parosmia. Any thoughts there about, the trajectory that people experience in terms of getting parosmia?
So certainly within the small fraternity of rhinologists, this is something that we have recognized certainly during the pandemic. And I had a small meeting with some colleagues last week, and all of us around the table did recognize that there is evolution of the olfactory dysfunction, and it varies quite significantly from patient to patient. The most common certainly is quite severe hyposmia or even complete anosmia of a particular duration, followed by hyposmia, and then it transitions to parosmia. And how long does the parosmia then last for? I think at the moment it's very, very difficult to predict, because most of our patients who had, say, for example, COVID in spring last year would have only just about completed 1 year of follow-up. So I think it's an area that we still do not know where the finality of it would be or the directionality of that would be. I think over time we would have greater clarity as to the final clinical outcome of patients' olfactory dysfunction.
Thank you. One thing I've heard anecdotally, and I get this is sort of going to be very much your view about it, is that for people who've had anosmia during COVID, who are then moving into a fade of parosmia. There are quite a few people who've been told, and it's discussed quite a bit, that the parosmia is a sign of some kind of recovery. What's sort of take to a temperature check on that from your point of view? What's the views on that you hear?
Well, if one is completely anosmic, that just means that the olfactory nerve ends are no longer functioning. Whereas when one has then parosmia, that is certainly a sign that some of the nerve ends are functioning, but obviously it is functioning to the point where the neural interconnections in the networks are either confused or misfiring. And that is where I think smell training comes in, really, to try and alter those new neural networks that need to kind of form in the remaining or residual nerve ends that are still functioning.
Got you. So it's the nerve endings, you got some function in there, but the message is essentially getting garbled.
Yeah, I think the analogy would be, say just a hypothetical scenario that if all of us had just 100 nerve ends that tell the brain that we're smelling everything in the environment, and say, for example, perfume Chanel No. 5 requires 65 nerve ends, and after a COVID event or a viral event, we have only 50 left. Now, what we don't know is are all 50 left subsumed within the original 65 that was working for Chanel No. 5, or is it a mix? But either way, if we have 50 left and it's a mix of the ones that were within the original 65 and also a combination of the ones that were outside the 35, then obviously the intensity of that particular odor and the characteristic of that particular odor will be mismatched.
Gotcha.
That's sometimes how I use the analogy to explain to patients, because they are significantly concerned about what they perceive, especially complex smells that don't smell complex anymore, or becomes very, very altered.
Thanks. That's a great analogy, because whenever I've read about or talked to perfumiers, there's some quite weird ingredients in perfume, and I really love that analogy, because if your smell receptors were just picking up some of the weird and not some of the floral, then you would have a quite an odd smelling one.
Because if originally you required 65, that then assumes there's this very complex interplay.
Sure.
But after the event, if you have less than 65, and you don't know what that combination might be, it will all smell abnormal.
Thank you. Something else we sort of picked up a little bit and opened up, and certainly I've been thinking about since our session, was the fact that if we look at hearing loss, we know that it's not just on or off, that you could lose the high frequency or low frequency sounds. It could get a little bit garbled. You wouldn't be able to tell background from foreground. You could have a ringing. There's so many different experiences that we could tee into, but we're still developing this language for what changes in smell can be, and the variety of different changes that can come up there as well. And I think that really gets into it, just that it's a highly, highly complex process. And so that we can't just be talking about can you smell or can't you?
No. And certainly if you take the parallels in hearing problems, some people, in addition to having objectively tested hearing loss, they also complain of tinnitus. And tinnitus is a subjective ambient noise in the background that there is no test for. And again, how that neural networks work or not work, we just have no idea. And I don't think we are at the level, the technological level, to kind of explain all of that yet.
Got you. Thank you. One question really backs this up. I've suffered with Phantosmia for 4 years. I've had many tests, an MRI scan, consulted Professor Philpott, still have the problem, cannot decide whether the nasty smell is actually in my nose or in my brain. And I get from what you just said is...
I empathize. We have similar patients like this in Liverpool in our clinic who have had numerous tests and scans. And certainly the MRI scans, it's reassuring to provide anatomical correctness of whatever that we want to rule out. But then we're still nowhere close to explaining why said patient has Phantosmia. It does help draw a line under the more sinister causes, but we're nowhere close to explaining.
Thank you. So let's go on to, so we've had a look at what it is and what some of the key causes could be. Oh, just another question we had about causes. Can it be caused by stress? You did mention stress being something that can come into the picture.
Yeah. And again, that is not common, but I've certainly had one or two patients over the years where it seems to be linked to stress or fatigue. And again, normal scans, relatively normal tests, as far as I remember. But it was just a pattern that was noticed by the patient. Certainly, every time the patient came to clinic, the endoscopy was normal. The smell tests were absolutely within whatever limits that we were expecting the patient to have. But it was just, again, very, very subjective.
Thank you. One other specific one before we get into treatments. I have phantosmia. I have an MRI and CT scans, which are clear. Bending forward, I sometimes get stray sensations of awful smells. So that points perhaps to something physical in the nose. Is that something you come across as well?
Bending forwards does two things, I think. Number one, for a while, it slightly alters the drainage of all the various different sinuses, because obviously the sinuses drain kind of by gravity. That's number one. Number two, bending forwards sometimes provide increased blood flow and blood pressure within the confines of the brain, and whether or not that changes the functionality of the olfactory bulb, I don't think anyone knows.
Okay. Let's go on to treatment. So you talked about, we're going to, if I can ask about sort of smell training, other therapies, and then medical. So if we look at those three in order. So the smell training you said first is about then rewiring and re-educating the neural firing to help try and create a pattern in our minds, which is closely to the previous reality. So the smell training in that case is looking at standard smells that we know, if I understand that right.
Yes, and certainly the Fifth Sense website will have a very comprehensive smell training regime, and that's certainly the web page that we tend to signpost all our patients to, and yeah, I don't think that there is evidence that one needs to vary the smell test regime of the program anyway.
Yeah. Thank you. Well, there was some more questions there as well, because it's very specifically triggered. Things like onions, garlic, mint. What else was coming up as a trigger? Various different kinds of meat for some people. Another person, wine or cheese was coming up as well. Is there any value about actively going towards those triggers to try and do a smell training with the triggers, or is your advice to go to elsewhere?
So in addition to smell training, what I almost always will encourage our patients really is to consider smelling complex smells as well. And certainly I would suggest wine, for example, and not necessarily consume wine, but also but smell wine, because there is a label at the back of the bottle to kind of then try and make that correlate. And that, I think, also helps with the rewiring of those neural networks. Appreciating that, yes, sometimes it does trigger parosmia or sometimes even cacosmia. But I think it's important to kind of push the remaining neurons to kind of fire again and kind of cause all those reworking of networks. So certainly, yeah. In clinic, I will signpost patients not only to the smell training, but also suggest to them that they should actually train on more complicated smells or odors, like wine, for example, like food, for example.
And very specifically, if somebody has a trigger, so say if somebody has, I mean, a lot of people are getting triggered by onions and garlic post-COVID. If they have that trigger, is there any value about actively trying to smell train with that trigger? I
think so, because, garlic, wine, vinegar, for example, that's one of the triggers I remember a more recent patient said. These food types are so common in our diet, and I think the sooner the brain is exposed to these kind of food types, and then allow for rewiring and retraining, I think the better.
Got you. So it could be a very unpleasant process, but
yeah,
there could well be value in it.
Yeah, I think to some extent going cold turkey with the retraining, or I think probably in the medium long term will bear some benefit or good outcome anyway.
Thank you. But I guess people could choose one then rather than hitting all of them
rather
at
than
once,
the whole, rather than the
which could
entire
be too
platter
much.
of stuff. But they can choose one and then work their way towards more and more complicated or food items. Yeah.
Thank you. I mean, we had a lot of ideas about how people can change their diet to help them out. In particular, there's something called the FODMAP diet, which I mean, it's for something different. It's for IBS, but that pulled up a whole load of ideas that came up for how people could change their food. So that's quite a nice idea. They could change their food so they're not actually able to eat, of course, because they're too unpleasant, but still do some kind of exposure to the smells that might trigger them in a much more controlled way off to the side. Great, thank you. I mean, another tip we had from somebody else was to change the background smells. He was putting in sort of vanilla smells in his room, which he found actually was quite a nice way, because it sort of engaged his sense of smell, but in a direction which was more controlled again.
And I think a lot of these strategies are sensible strategies, actually. Not always possible to list them all out in the clinic consultation, and that's why I think sessions like this and also having fifth sense, hosting events for the public and for patients to reach out to, I think that's very, very important, because certainly we as clinicians will not have the time to kind of go through every single strategy that might or might not work for individuals.
Yeah.
And I think with people suffering with olfactory dysfunction, I think they need to approach every strategy with an open mind.
Yeah. Fantastic. No, and I really see that in the sessions we have, the number of times that people write in an idea and people say, oh, fantastic, I'm going to take that away. It's brilliant. So smell training, we had a quick look at two different types of it. Other therapies, have you found any use in them? So if we look at, for instance, we had things like homeopathy, CBT oil, hypnotherapy, any other approaches which you found have helped support people through this process?
So certainly we from the clinic will not have access to medicines that are not prescribable.
Yeah.
And we will have some constraints in terms of recommending those, because they are either off license or not necessarily indicated from a medical perspective. Treatments that we're then able to prescribe from clinic largely are saline nasal irrigation, saline nasal spray, or topical steroids. Whether the topical steroids are in the form of spray or drops, that is certainly dependent on the clinician's preference. Certainly with hyposmia, what I found is topical steroid drops have resulted in greater improvement than sprays. Again, very anecdotal, and it varies significantly from individuals to individuals. When it comes to parosmia, and certainly because we're seeing far more parosmic patients in our clinics during the pandemic, it is still too early to work out what the clinical outcomes are. But certainly I will recommend a trial of saline nasal irrigation, and on top of that, some steroid drops for these parosmic patients. Some have reported that the parosmia becomes more tolerable to the point where the parosmia then becomes hyposmia. Others have noticed no change whatsoever. And again, it's all very anecdotal at the moment, certainly from our clinics in Liverpool.
Thank you. So the use of steroids is still the jury's still out on it.
I think the jury is still out. And overall, topical steroids largely do not have a systemic absorption profile. And there is no reason why one can't trial it, for a few weeks, for example, to see in conjunction with other strategies, like say smell training and saline nasal irrigation, and whether or not that changes the clinical course.
I know. So I guess what as the causes are unknown for why it is that we're misfiring, getting this slightly garbled message in the brain, an aspect of it could be inflammation, which the steroids would help with.
Could be, because most of these will be post-viral, so you will expect, an element of inflammation. We are seeing patients currently in summer, so it is the height of pollen season as well, so that there will be lots of overlaps to what we see through an endoscope. So there is no reason why for a short period we can't trial topical steroids. But obviously, if there is no clinical change, then there is no medical indication to continue. Then
Thank you. Just some specific drugs people were mentioning. Amitriptyline, is that one of the steroids you were mentioning?
So amitriptyline is not a steroid.
Oh, it's not. Okay.
No, certainly it's been considered in some patients with Phantosmia. I think with Parosmia, certainly less so. And I've certainly not prescribed amitriptyline for the post-COVID parosmic patients that I've seen.
Got you. Yeah. Last couple of questions then. So vitamin A came up a lot in discussion. How do we take it? Where do I get hold of it?
Sorry, say that again. Oh, what?
Vitamin A.
Oh, vitamin A.
Yeah.
Vitamin A, I think if you look at the studies that have been published with regards to vitamin A, and including, in addition to vitamin A, even omega-3, there have been some studies published from America, and the concentrations are important. And actually, you can get vitamin A tablets, obviously from your health stores, similar with the omega-3 as well. And again, there is some evidence, but not overwhelming evidence to suggest that it works. And like most of these clinical studies, the outcomes or the responses are not 100%. And it's impossible to predict one's or the individual's response to these kind of therapies. That's why I come back to what I said earlier, that whatever strategies that the individuals want to consider, do consider each strategy with an open mind.
Thank you. And
outcomes are not binary.
And is vitamin A taken as a drop nasally, or is that taken orally as a supplement?
The omega-3 is taken as a supplement, a tablet supplement.
Yeah.
Whereas the vitamin A, there have been some studies where it's used as a drop. So again, it's a lot of this are available, when you do a Google search. But do approach all of these therapies with an open mind, really, because certainly clinicians within the NHS won't be able to prescribe, and sometimes clinical recommendation might not be as positive as one would expect, just because the clinical evidence is not as strong as one would like it to be.
Thank you. And if people were going to take vitamin A, is that something they should do in consultation with their clinician?
I think there is no reason why they can't raise these issues in that consultation, and obviously the response from the clinicians will vary depending on which clinician they see. They might get less traction with their general practitioners, maybe more when they see a rhinologist with an interest in olfaction. And again, it's approaching all of these with an open mind, and it's trial and error. Similar with topical steroids, if one gets a prescription for topical steroids, there is no guarantee that the individual will respond positively to topical steroids. It's a trial and error.
Got you. And I understand sometimes people are really searching for an answer, a yes, no, and some certainty around this, and that's absolutely understandable. But it is also knowing that this is a highly complex area, that understanding is still ongoing in there, and there aren't any sort of, those clear answers we would like to get are still not.
And I empathize, it's a very difficult consultation, and increasingly so, because people are obviously very worried about the COVID to begin with, and the implications of the pandemic on normal life. What more having to contend with olfactory dysfunction, it's certainly a very concerning thing for many of the patients that we see in clinic. Yeah.
Thank you.
And we're not able to give that kind of finality, and that's the problem as well, because we know so little about this. Even pre-COVID, we knew very little about olfactory dysfunction.
Yeah.
Yeah.
Thank you. Sam, thank you so much for your time today. Just before we started recording, tell me you've got a very busy day ahead of you. So I wish you well. Thank you very much for your support
so
ongoing
much,
for Fifth Sense and for your time together today. Thank you.
Thank you so much.
So we've covered all the questions we could. That was half an hour out of Sam's time. I did promise him it would only be 20 minutes. So thanks again to Sam for all of that, that thought and idea and his time together today. From the questions that we took from the session, there might still be a few outstanding. If there's anything left over for you that feels unanswered, do let us know and we can pass that on to Sam or one of the other clinicians that we work with. Hope this has been useful and keep an eye out for our future events on Let's Talk, Smell and Taste.